Hi everyone, I welcome you all to this very special series, Labs to Clinics with Microbiology. So I'm going to discuss the infectious disease perspective of microbiology and some important and interesting clinical cases which you will come across very commonly, frequently. And often it happens that what we read in the books, the presentation of the patients actually in our clinics differs a little bit, and diagnosis becomes a mystery in itself. So those of you who have joined us, please come and say a hi in the chat box. It would be very nice to see all of you. If you have joined, then if you can say a hi, then we may start. So basically today's lecture I'm going to start with a very special topic I selected because I thought this is probably the most common clinical presentation that you come across in life also, and also a very favorite question, because fever with rashes is a very favorite of INICT, also borrowed from in NEET PG, and for second year MBBS it is very important as a long question, right? Because for the long question they often give a clinical based scenario with multiple options, so you might get one of these questions also, right? Good evening, Marzia. Very nice to see you always, as one of the first ones to join always. So if any more of you have joined, then please come and say hi. I would like this session to be interactive because this session is meant to walk you through history taking, relevant examination, and the points that you might miss while dealing with the infectious causes of any kind of a rash that the patient might present with when the primary symptom complaint is fever. Right, guys? So, I have brought a case for you. So, we are going to not get scared by the long clinical stem or the long case that is there, because that has been the trend of many competitive exams also this year, where long clinical questions and scenarios were given to you. So, it's important for you to identify the buzzwords from the questions, and it is important for you to pay attention to the relevant history of the patients also, right? So we are going to work together and we are going to solve this case that we have. So a 10-year-old boy from a socioeconomically disadvantaged background presents during the peak of monsoon season. So there seems to be quite many points of relevance over here, with a 4-day history of high grade fever documented up to 104 degrees Fahrenheit. Now, this is something important that you have to elicit in your labs, as if you have started going to your medicine department or your clinical postings. Many of your guides, teachers and mentors must be telling you that whenever you talk about fever, you should only call something high grade, low grade, or likewise if you have documentation. If there is no documentation, you should mention the same in history, right? His mother reports associated severe frontal headache, eye pain, generalized myalgia, nausea, redness and watering of the eyes. Does it not look like a common, it also kind of looks like a seasonal flu, right? But he's come to you in the peak of the monsoon season. So I am thinking that I should probably highlight peak of the monsoon season, 4-day history, high grade fever, and there is headache, eye pain, myalgia, nausea, redness, watering of the eyes. He has developed a generalized erythematous rash involving the entire body. If you guys think that there is any other important factor that I should underline here, then please you may comment and then we can take up that important factor as well. From the first looks of it, these are the important things that you might be noticing in the history, right? So this appears to be what we call as fever with rash, right? So every time you approach a patient of fever with rash, there are a few things that you need to consider. Every time there is fever with rash, the causes might be infectious, the causes might be non-infectious, right? So if these are non-infectious causes, it would be autoimmune, drug-induced, or malignancies. Now, amongst the autoimmune, there is the SLE, and there is many drug-induced rashes which might happen. But we are going to focus today on the infectious causes. Now, based on this history, as a clinician, how do I rule out that this is actually an infectious cause and not a non-infectious cause? Can anyone answer in the chat box? Because the patient is not going to come to you saying that, okay, this is infectious fever with rash that I'm having, Right, guys? Anybody who wants to participate is always welcome to participate. So what I'm noticing from this history is that this is a acute history. Yeah, relatively acute history is happening. It's just a 4-day onset of fever. If it was any autoimmune or malignancy kind of a situation, the patient would have given the clinical or classical history of repeated onset of fevers with rashes. Okay, on multiple occasions, even in the past, the fever and rash must have come in the patient. And drug induced, so for that I need to elicit the history of drug intake, history of any medications I need to elicit. So always remember that that is one important history that you need to find out. What else do I want to notice? So I have said that this is a erythematous rash. So probably it is a maculopapular kind of a rash. Probably, because otherwise they would have written a blister, a fluid filled pus. So every time you come across a rash, you need to first find out what kind of a rash it is. So the most common presentations are going to be, if it is an erythematous rash, right, then it could be a diffuse red skin where there is just congestion, which is commonly seen in autoimmune disorders. But the erythematous rash, which I have told you in the history, basically when you just look at the patient, or when the patient is just telling you the history, they're just going to tell you that they have red rashes all over the body. They could also be maculopapular. You understand that a macule and a papule are flat rashes which are completely flat along the skin of the patient, right? There is absolutely no razors which are there. But the special thing about maculopapular rashes is that they are blanching rashes. Okay, blanching. So this is what you need to find out, whether it is blanching or non-blanching, because then you want to know if you're dealing with a maculopapular rash or you're dealing with a petechiae or purpura. Petechiae or purpura happens whenever there is bleeding into the skin of the patient, whenever there is any kind of bleeding abnormalities. So when the petechiae are less than 3 centimeters, 1 centimeter, we call them petechiae. When they're really tiny, when they're more than that, we start calling them purpuric rash, right? In both of these, there is going to be no blanching. Right? Blanching is not going to be there. What is the meaning? When you press upon the rash, the redness goes away, and for a little while it becomes colorless, and then the redness comes back, right? So I am believing that that is another history that I should ask from the patient. So up till now we have 2 points: any history of intake of medications. Secondly, I should examine the patient for whether the rash is a maculopapular type, or it looks like a petechial or purpural rash, whether it is blanching or not blanching. Then vesiculobullous or vesicular rash is something which is fluid filled. It is raised and dome shaped with fluid filled inside, becomes a vesicle. And when it is enlarged more than 5 centimeters, we call it bullae. And when it is filled with exudates or pus, we call it pustules. We have read the viral exanthem diseases of childhood, and we understand that the viral diseases, exanthem means rash on the exterior surface, constitutes of diseases which range from maculopapular to vesicular bullous rashes as well. Right? So let's go back to the history and let's try to elicit the maximum from here. So of course, I'm going to ask first the medicine intake from the patient, right? So to rule out whether it is any kind of a drug-induced reaction or not. So the mother tells me that no such relevant medicine, only antipyretics has been taken, only antipyretics, which is paracetamol, has been taken by the patient because he was having fever since how many days? Since 4 days he was having the fever, right? Great. Specific out of area travel. Why do you think I have written this? Any takers? Why do you think I have written specific out of area travel? Because I want to find out about your arthropod-borne, tick-borne fevers. So every time we come across a maculopapular rash in the patient, we have to find out if there was any kind of travel to forest areas, because there could be tick bites, mite bites, and we understand that many viral hemorrhagic fevers happen after bites of mosquitoes and ticks, and also important rickettsial illnesses of the bacterial origin also happen like that. So the mother tells me that no, there is no specific out of area travel. Why pets? Why is it important to elicit the history of pets? Why is it important to elicit the history of pets? Of course, you're going to go into the detail of fever and everything. I'm not covering the details of fever over here, because that is more pertaining to other causes of infectious diseases where you have fever with rash. It is the rash which becomes more important to elicit the history. That is why we are focusing more on rash and associated histories. So currently the most commonly missed associated history is what I am focusing on. So always ask what medicines the patient has taken so as to rule out drug-induced infections, specifically rule out of area travel, travel to forest areas, camping or history such as that. Exposure to pets, if they have any dogs or cats in home, or whether there was an exposure to rats, etc. Again, because of the pets, there could be exposure to fleas and ticks, etc. And the mother tells me that there is no history of pets. Then prosthetic material. Why do you think I'm asking this? Any kind of a foreign object inside the person. Now see, it's a 10-year-old male, it's a 10-year-old child, right? It's a 10-year-old boy. So at this point of time, if you want to suspect, don't you think you also want to suspect toxic shock syndrome, right, which happens because of Staph aureus? That also presents with rashes. So any kind of a but tampon use history is not going to be there in a 10-year-old boy. So tampon is not compulsory, that is the most common cause, but any kind of a prosthetic or foreign substance or body inside the cavities of the person may lead to such a scenario also. So some very, very important histories we have elicited in order to rule out infectious causes in this patient. Then rash specific history we are going to focus on. Okay, what was the onset of rash? We already know the onset of rash. When was the onset? I said yesterday. So that means on the day 3 of fever, right? There is the previous day he gave generalized erythematous rash all over the body. So it's been 4 days of fever, and it's been okay, and it's been 1 day since the rash. So of course onset is on day 3 of fever, right? Day 3 of fever is when the onset of rash has come, right? Site of onset, where did it begin? Where did it begin? Most of the time when you try to elicit such a history from the mothers of the patients, they will not be able to tell you specific site from where the rash has erupted. Sometimes they may not. What has the mother given us the history of? All over the body. You know, if it is just the trunk involved, then the common terminology or the words that the patients might use is pure sharir pe. I have the rashes all over my body, right? So in such a scenario, it is important to ask that where did it start? So when I probed further, the mother was able to tell me that they started from his neck. From the neck, right? Direction of spread, it started from the neck and then spread to the trunk, then spread downwards or to the trunk. This is what the mother is telling me. Okay, rate of spread I am asking. How fast did the rash spread? So it's been 1 day, okay, and within a single day the rash has been able to cover from neck to the trunk. So I am guessing that in the next 2 days I have to focus on that how much is the rash spreading. Is it able to cover your cephalocaudal area, right, within 2 to 3 days. Fever association, she says that there is no much fever association. The fever is still persistent despite the appearance of the rash. So fever association, we ask whether fever is subsided as soon as the rash started, because in many infectious diseases, when the rash appears, the fever subsides. If you want to give me some examples of those diseases, then you're always welcome to write in the chat box. that in which diseases is fever subsiding associated with eruption of rash, right? So she says that fever is persistent. Fever persistent with eruption of rash. Okay, so I am able to understand that rash and fever is going on simultaneously. The rash has started from the neck and it is spreading downward. So it is spreading in a head to toe kind of a fashion, and any associated symptoms. So of course, she's given me the history of headache, eye pain, watering from the eyes, etc. Right? We have just seen this. When we did the examination of the patient, we found that there was mild tachycardia. Mild tachycardia. If I had said that there was relative bradycardia, what could you have thought of? What could have been the other situations? There is mild tachycardia. This is a normal scenario. Patient has fever. Of course, there can be mild tachycardia. What if there was relative bradycardia? Then it would have meant something, right? Then it would have meant something if there was relative bradycardia. Can you mention in the chat what is the DD of a relative bradycardia? What DD do you think I should write here? Then the patient is normotensive. Now this is the most important thing here. Every time you get a patient of fever with rash, you want to rule out infectious versus non-infectious. We have ruled out no history of medicine and abrupt onset disease. So we have mostly ruled out non-infectious. We want to focus on infectious causes because there is strong history association with monsoon season, fever, pains, retroorbital pain, and rashes erupting on day 3 of fever, right? Then I am seeing that the patient is normotensive. So you understand that in meningococcemia, in meningitis, especially gonococcal meningitis, patient often presents with petechial rashes all over the body, right? So that is an emergency. So if the patient, at least I know now that the patient is not in shock, not in shock. Okay, so up till now, I know this, that there is tachycardia and the patient is not in shock, patient is normotensive. Then I look at the rash further. I see that it is maculopapular, it is blanching type, and I noticed that it had started in the post-auricular region also, not just in the neck. When I look behind the ear of the patient, there was rashes behind the ear of the patient and it is spreading to the trunk. So I understand that this is what kind of a spread. This looks like a centrifugal spread sparing the palm and soles. Sparing the palm and soles. And on eyes, there is conjunctival injection. There is redness of the eyes, which the mother had also told. Mild photophobia and retroorbital tenderness. However, there is no icterus, that is no signs of jaundice. What all do you think are the DDs of this patient? DDs, come on guys, DDs. So basically, when the patient came with what? 10-year-old boy, poor socioeconomically disadvantaged background. I understand. What else can be there? Let's write the buzzwords. Crowding. This is telling me crowding. Yeah. Peak of the monsoon season. Peak of the monsoon season. So every time monsoon and fever with rash, shouldn't I think of dengue? Shouldn't I think of dengue? If it is monsoon, then rat urine, rain and rice fields. So with rain, I should also think of leptospira. Leptospira, yes. Again, that also has fever and rash. Associated, say, frontal headache, eye pain, generalized myalgia. This is also pointing towards dengue. Redness and watering of the eyes. There seems to be some kind of a conjunctival suffusion. Now that can happen both in dengue and leptospira, right? Since now the rashes he is talking about is generalized erythematous rashes, which we have also talked about. So whenever we see maculopapular erythematous rashes, our DDs become these central maculopapular rashes. Now this is straight out of Harrison. Whenever you spot maculopapular rash, you should see whether it is happening in the central part of the body or it is happening in the peripheral parts of the body. Over here in my patient, where did it start? It started from the neck and involves the trunk, and it is moving out of the body. Centrifugally it is moving. But it is sparing palms and soles. See, I had written that it is, on examination I am seeing that it is sparing the palms and soles. And every time there is a peripheral maculopapular rash, means it is going to start from the palms and soles. So for both, you will have both the kinds of DDs, which I will tell in just a little bit, right? So now let's talk about central maculopapular rash. I had said acute meningococcemia because of your gonococcal meningitis. But how am I able to rule that out? Because the patient is normotensive. There is no hypotension, there is no shock. So it cannot be disseminated gonococcal disease. Yes, it cannot be disseminated invasive gonococcal disease. So this can be ruled out. Measles. Can I rule out measles here? Can I rule out measles? I know that measles has the characteristic 3 C's, cuff coryza conjunctivitis, plus the Koplik spots. There is no mention of Koplik spots here. Yes. Plus there is the rash, and at that time the fever subsides. But there is no such association of fever subsiding with rash. Rubella. Can it be rubella? Of course it can be rubella too. Then amongst the children, why am I writing measles, rubella, fifth disease, sixth disease? What are these? These are the viral exanthems of childhood, right? So, if we talk about the viral exanthems of childhood, you know that it can either be maculopapular or it can be vesicular. Maculopapular to vesicular can be hand, foot, mouth disease, which is caused by Coxsackie virus. It can be your varicella, chickenpox, right? Then amongst the maculopapular, you have the measles, rubella. Then you have your fifth disease and sixth disease. So, of course, we're talking about fifth and sixth. What is fifth disease? It is called as erythema infectiosum. Remember, erythema infectiosum, the fifth disease, we always tell you how do we give a slap with all 5 fingers, and every time you give a slap, your hand also pains. So in adults, there's going to be arthritis, right? So erythema infectiosum, slapped cheek, and arthritis. Who causes it? Parvovirus B19. Parvovirus B19 causes your erythema infectiosum. Sixth disease is roseola infantum. Why is it called as sixth? Because HHV6 associated more than human herpes virus 7. Remember, roseola infantum. Why? Because there were the pink rose colored spots, the blanching rose spots which were happening. Blanching rose spots. Okay. I see the blanching rose spots. Have I been able to rule out erythema infectiosum? Yes, there is no slap cheek. Have I been able to rule out HHV6? Usually happens in infants where there is bulging anterior fontanelle and the blanching rose spots, right? Typhoid. How can we not talk about typhoid? In typhoid also there is the rose spots. So we cannot rule out typhoid yet. Leptospirosis, like I said, it is associated with jaundice, conjunctival suffusion, and rashes can be there. But there seems to be no jaundice. But let's still wait. Dengue, of course it can be dengue. Can it not be dengue? It is monsoon season. Of course there can be mosquitoes. There is rash and fever which is there. I have not been able to come up with the history of 3 C's. I have not been able to come up with the Koplik spots. But I have been able to come up with maculopapular rash along with fever, along with the peak season for dengue. Then epidemic typhus. Now we have come on to the rickettsial, group. The bacterial causes, all the hemorrhagic fevers caused by rickettsial group. So epidemic typhus, remember I always tell you epidemics are caused by louse or lice. So you know that it is louse-borne. Louse-borne. And I have said that the patient belongs to poor socio-economic demographic. So of course there can be overcrowding. So up till this time, what are all my DDs? I can definitely think of measles. I cannot rule out rubella either. It could be sixth disease. It could be leptospira, typhoid, dengue, and epidemic typhus also. Right? Epidemic typhus also. It cannot be the other causes of rickettsial illnesses, because for that you would need the tick and lice, and for that you would need the tick bite, and for that you would need, going into the forest, etc. So that is less likely. Also scrub typhus and everything, there is no black eschar. I am seeing maculopapular rashes. So now it is upon me to slowly and slowly rule out all of these agents. So what is the first thing that I should ask in order to rule out all of these agents? So what are my DDs? Let's write. My DDs up till now are dengue. It looks kind of like dengue to me. Then it is leptospira. Leptospira. We have not been able to rule out typhoid or enteric fever either. Yes, typhoid or enteric fever, salmonella. We have not been able to rule out that either. Then we have measles. Then we have rubella. Measles and rubella. And what else was there? Yeah, more or less these 5. Oh, epidemic typhus. Yes. And number 6, epidemic typhus. If you remember, rickettsia provarzicae, because of the louse infested pro-war soldier, right? Thank you, Shiveha. Right. So let's continue. Investigations when you will do every time for to rule out any infectious disorder. Of course, the first thing that you start with is CBC, right? CBC is going to tell you the basic detail about whether it's an infectious etiology or not. I suspect that whenever there is infectious etiology, there should be a lymphocytosis kind of a picture. There should be raised TLC counts. WBCs should increase whenever there is any kind of an infection. Then I need to do the differentials of whether it is neutrophilia or it is lymphocytosis or what is happening. And I'm sure, with your pathology knowledge, you understand all of this. But here you see, there seems to be lymphocytopenia. The TLC is not raised. It is in fact 4.2 K. Hemoglobin seems normal and the platelets are also not markedly reduced. If I was suspecting dengue, then I should have definitely thought of deranged hematocrit and thrombocytopenia. That does not look like in this picture. Why did I do an LFT? Why did you do an LFT? Because you wanted to rule out leptospirosis. What will happen in leptospirosis? There will be deranged liver profile. So deranged ASTs, deranged bilirubin profile, because the patient must have jaundice along with your rashes. So this is also normal. This okay. Then CRP is mildly raised. Again, this is pointing towards some kind of an acute infectious etiology. Blood and urine culture. Why did I send blood and urine culture? Because I wanted to rule out your typhoid also, enteric fever. They have, for aerobic bacteria, they have come out to be sterile. Now, at day 4 of illness, the blood culture, if it was typhoid fever, should have come out to be positive. So that is also kind of giving me an idea that probably this is not typhoid. Then, of course, for dengue, we will do NS1 antigen. And since we were really looking forward to dengue, NS1 has come out to be negative. Why did I not mention tourniquet test in examination? Because it is not always very substantially that it can come out to be positive unless it is short dengue, right? So dengue NS1 being negative, so I confirm with dengue IgM, that has also turned out to be negative. And it is the day 4 of illness which is happening. Dengue IgM and NS1 negative. What is MAT? What is MAT? Remember, microscopic agglutination test. MAT. Cat sat on a mat with my brother Lee. So MAT is Lee. MAT is leptospira. That is also negative. So all negatives for leptospira were anyways pointing out that there was no icterus in the patient. The LFT of the patient is normal, and now MAT has also come out to be negative. So we can, I think, rule out from here. We can rule out leptospira. Then our blood culture is negative. Then typhoid remains kind of towards the negative. What about dengue? Dengue has also been ruled out because of NS1, right? We now remain with measles, rubella and epidemic typhus. So for epidemic typhus, what should we do now? We should do the very famous Weil-Felix test. Weil-Felix test, the heterophile antibody detection test, that has also come out to be negative. So finally, to rule out measles and rubella, we have done measles IgM, which came out to be positive. So we should definitely confirm it with a PCR. With a PCR for measles is what we should confirm it with. So now, don't you think that such a history is actually pointing you towards measles? When the peak of monsoon was telling you that it could be dengue, leptospira, when low socioeconomic status was telling you it could have been any rickettsial hemorrhagic fevers, when the type of rash was telling you that it can be any of the viral exanthem diseases of childhood, right? You have to come out to be measles. But what did I say? The 3 season Koplik spots, what about it? Don't you think we missed a very, very important thing in examination here? When we did the examination of the patient, why did we not look for Koplik spots? That is what we have missed. That is what we have missed, right? Koplik spots. Also, when we look at the lesion closely, carefully, if I look into the lesion, I can see that the maculopapular rash is advancing in such a manner that it is coalescing together. The rashes, they coalesce with each other. That is one of the pointers towards measles again. So every time you are not going to get the classical cough coryza conjunctivitis, it might not get elicited in the history, but every time you have a child, you should definitely ask for immunization status of the patient. That is what we did not ask here. So where did the immunization history go? Had we taken the immunization history, we would have definitely not gone through so much of trouble to come to a diagnosis, right? It has to be an unvaccinated child. So let's see what happened then when we probed further. Retrospective examination and history. Based on the measles IgM results, we were not expecting a measles IgM to come positive. Then we went ahead and we delineated Koplik's spots. You remember what are Koplik spots? Against the third molar, there is the whitish raised spots with a red erythematous background. That is Koplik spots. However, Koplik spot, the appearance of rash is after the disappearance of Koplik spot. But we are on day 4 of illness, right? We are on day 4 of illness. So there could be an overlap. So to revise, what was the timeline for measles? What was the timeline for measles? There was a long incubation period of 10 to 14 days. Right? Then let's say on the 10th day, what are the first symptoms that used to come? The 3 C's, cough, coryza and conjunctivitis on day 1 plus fever. Then on day 12th, 2 days after that, there were the enanthems, the Koplik spots, the enanthems. 2 days after that, on the 14th day, there was the exanthem or the rash. And usually the Koplik spots would disappear with the appearance of the rash. However, we are somewhere here on the 4th day. So there might be a possibility that there is some overlap and you can see the fading away of the Koplik spots. So never miss out on a examination of the buccal mucosa. Unimmunized child, when we elicited the history, we got to know that the immunization was incomplete because the parents had denied the immunization. History of mild cough coryza on day 1 to 2 of illness. Since it's the peak of monsoon season, the mother did not think it was important or necessary to give the history of mild cold-like symptoms that the child must have experienced 2 to 3 days before. So if you will keep the DDs of measles also and not get biased and distracted by all the peak of monsoon and everything which is going on around you, then you can save precious time and not get confused by the other DDs which could have been, right? Awesome. I was also telling you about peripheral eruptions. Since we are talking about fever with rash, we've understood whenever there's fever with rash, first we need to find out about the immunization status of the patient, immune status of the patient, then the association of rash with fever, then how the rash has been progressing, whether it is cephalocaudal, whether it is centrifugal or it is centripetal, is it a central rash or a peripheral rash, then is it a maculopapular rash or is it a vesicobulous rash, or it is a nodular kind of a rash. Then with a centrally spreading maculopapular rash, all the DDs we have seen, right? Then if it was peripheral, then it could be Rocky Mountain spotted fever. But what was the speciality of Rocky Mountain spotted fever? It starts from ankles and wrists, okay? It spares the palms and soles, but starts from ankles and wrists and moves centripetally, moves from outside to inside the body. And of course, there is going to be the history of tick bite. Tick bite. Yes, you remember? Rick mountain tick, rickettsia rickettsii, Rocky Mountain spotted fever, tick bite. So there would be the history of travel to outside specific areas, either to the mountains, to the jungles, etc. Secondary syphilis. Of course, it's a 10-year-old child, so that is a little unlikely, but you should always try to elicit the history of STDs, the histories of risk of STDs in your patient, right? What will happen in secondary syphilis? So there would be a healing single genital ulcer in the past, which the patient will forget about. And now the patient will just come to you with fever and rashes on palms and soles, remember, on palms and soles, and they are scaly kind of lesions, scaly lesions on the palms and soles, and the mucus patches on the tongue, and there could also be the thinning of the hairline. So all of the specifications of secondary syphilis you should not forget. Then of course, hand, foot, mouth disease. Name itself says it is near the mouth, on the hands, on the palms and soles. You get the vesiculobullous lesions. They might start as maculopapular, but then they will move on to becoming your bullous and vesicular lesions. So even if you get maculopapular, do not rule out hand, foot, mouth if at all palms and soles are getting involved, right? Then you have bacterial endocarditis. How come nobody thought of that, right? If you have peripheral lesions, then bacterial endocarditis is also a very important DD. Remember the Janvey's lesions on the palms and soles and the Osler's nodes, the nodular lesions, they can also be found in bacterial endocarditis. Right. This is just a list to give you all the important viral exanthem diseases of childhood. You have, of course, measles, which happens in winter to spring months. Of course, so monsoon season was one of the important seasons for your measles virus to spread. We have just then begins at the hairline and spreads inferiorly. You have to elicit 3 C's, Kopliks and high fever. Scarlet fever by streptococcus is also one of the important DDs. But what was happening in scarlet fever? Sandpaper rash and the strawberry tongue. So you had to talk about sandpaper rash and strawberry tongue. Then with rubella, there is also rose pink macular rashes. But what happens in rubella is, as the rash is progressing forward, the previous lesions, they start disappearing. What was happening in our child? Rash was present everywhere. It was present in the back of the neck. It was still present on the trunk. But in rubella, as it will move downwards, the upper clearing is going to start. Then we have seen the slap cheek, the sixth disease, herpes zoster or varicella chickenpox is going to be multiple crops of rashes at the same time. So there can be a vesicle, there can be a blister, there can be a macule, and there can be a scab all at the same time. And then of course the hand, foot, mouth disease by the Coxsackie group of viruses, which includes the hand, foot and mouth of the babies. This is another very famous mnemonic which you must have read in pediatrics, that every time you have a rash in a febrile patient, depending upon the day of fever and the illness, you have to think about certain diseases. So the mnemonic is very sick children must take double tablets. So on day 1 you have varicella or chicken pox, so you would have seen onset of fever along with onset of rash and a vesicular kind of a rash. So prodrome, fever and rash will come on day 1. Sick, scarlet fever, we have just seen the strawberry tongue, sandpaper rash and circumoral pallor. Then children, smallpox. So from children actually you can also remember it as patient, very sick patient must take double tablets. Then must, measles, take, typhus, we have just seen the epidemic typhus, double dengue and tablets is typhoid. So day 6 of fever if the rash comes, so after about first week of illness the rash appears in dengue, and then the rose spots can also appear in typhoid after about the first week of illness. Just a little bit about the measles virus. If you remember, measles belongs to the Paramyxoviridae family. Paramyxoviruses, yeah, which the mnemonic for which we had, remember, MMR. MMR, where it was measles, mumps and respiratory syncytial virus, not rubella, right? And we had said it is less. So we know that paramyxoviridae is just like the influenza viruses, only the difference is in the hemagglutinin and neuraminidase. So less means nahi hai. Kya nahi hai? Na nahi hai. Yes, na nahi hai and ha hai. Ha hai. We remember this. So we remember that it does not have neuraminidase, but it has hemagglutinin present in it, and it belongs to the Paramyxoviridae family. And we know that all Paramyxoviridae family, they are all single-stranded RNA viruses with a helical symmetry, and they are all enveloped, right? Enveloped. Why? Because it does not fit into any of my mnemonics. It does not fit into the non-enveloped mnemonic of my RNA DNA, which is the PAP and the Rota Rehta and Picorna. It does not, and since it's an RNA virus, it can be helical. There are only the, non-enveloped RNA viruses are icosahedral viruses, right? Okay. So if you want to do the lab diagnosis of measles, what all things you want to collect? So for lab diagnosis, you can take the nasopharyngeal swabs, right? Because we understand that the mode of transmission of measles is through the oral respiratory secretions because of the prodrome, which is the cough and coryza, which is happening. That is where the patient is also very, very infectious. So through the respiratory route it goes. So the nasopharyngeal swab is very, very important. Then serum of the patient can be taken to detect the IgM, which we did in this case where we detected the IgM for measles. Then of course virus isolation can be done. Remember what were the important inclusion bodies which it was showing? The Warthin-Finkeldy, cells. And if you remember the mnemonic, CM, Chief Minister of both the states. Remember the viral inclusion bodies, CMV and measles, CM. So Warthin-Finkeldy cells, CM. It is both intranuclear and intracytoplasmic inclusion bodies. Correct? So all the important points we have noticed. Vaccine. Let's talk about the vaccine for measles. Vaccine strain. So you remember Japanese chick on a Bombay train where M was MMR. So it was a live vaccine. It is a live vaccine. Measles is an example of live vaccine. And what was the mnemonic for remembering the strains? It was measles itself. Measles, right? So Moratin strain, Edmonston, Zagreb strain, and the Schwartz strain. That is the vaccine strain. Of course, treatment, there is no specific antivirals for measles. You just have to give, yes, correct. Edmonston Zagreb, correct, Marzia, very nice. So, you just have to give, no antivirals need to be given, only fluid therapy needs to be given to the patient, and vitamin A supplementation has been shown by WHO to be of benefit. That is why in the National Immunization Program also at the 9th month, along with the measles vaccine, we end up giving the vitamin A to the patients as well, right? Immunoglobulin in such a case can be given if at all there is indication that is the patient is heavily immunocompromised, an HIV positive child, or in such a scenario. In this case where the patient is comparatively stable, then the clinician may choose to not give immunoglobulins also, right? So that was all from my side, guys. Thank you so much for joining in. Next time I'm going to bring a lot more, many such interesting cases. The only takeaway from this message was that every time a patient comes with fever with rash, do not get biased by information such as monsoon season, which was the star of today's lecture. Thank you so much for joining. I will see you again. Bye-bye.